Okay, so let me introduce our first two guests are Tricia and Jeremy. Come on up, guys. These are two absolute experts in ACOs. And first time I heard Tricia speak about this topic was about 4 years ago, and I was like, oh my goodness, this has to be a part of our ongoing training for Sono, because the content is excellent, and we are going in this direction whether we like it or not. So we invited and requested and begged for these two to come and present to us. So guys, go ahead and take it over. Thank you so much for being here.
Thanks, Mark. Do we need to turn these on?
Can you hear me? Can you hear me?
Yeah, we got it.
Okay.
Yes.
How about me? How about that?
Yes.
We danced up here. How did you like that, Mark?
Okay, thank you.
So this morning we're going to talk about ACOs. Many of you may know about it, some of you might not, but first of all, I think you need to know the language. You need, if you're dealing in that space and working with insurance companies and various others, then you really need to know the terminology. We also want to share this morning the landscape, what does it look like? And then we're going to also share what options can you learn from others. It's kind of the feedback, is that okay? Okay, we need to separate. I'll stand over here. I'll dance over here. And then the other thing that we want to share is what steps can you take as hospice organizations to kind of prepare and be ready for this. So let's...
And so just as a slight introduction, so I'm Jeremy. I'm the Vice President of Strategic Initiatives for Midland. Sorry about the feedback. If there's something we need to do, let us know. But so Midland is a legacy not-for-profit hospice in Northeast Kansas. So in Topeka, Kansas, we've been around since 1978 and have been providing hospice care. Built the first hospice house in the state of Kansas. In 2007, we joined PACE, which we'll talk about later in the presentation, but it's Program for All-Inclusive Care of the Elderly. And then the way I got to know Tricia is through the ACO stuff that we do, and so we'll cover that later on as well. So.
And then I'm Tricia Ford. I'm over all of operations for Care Synergy. We're a parent organization to all of the not-for-profit home health and hospice organizations along the Colorado Front Range. And so we manage a number of different organizations. We do all the back office so that those organizations can do what they do best, which is care at the bedside. I covered this, so let's try this and see if it's any better. Okay. Do I turn off this? Yeah. So is that better?
Yep.
Can you hear me?
Much better? Okay, perfect. Yay! Okay, all right. So first of all, this is the terminology slide. I'm not going to cover it all, but there's a few that we need to really kind of reach out and point out. ACO, Accountable Care Organization. I want to point out MSSP, Medicare Shared Savings Program. How about VBID, Value-Based Insurance Design? So these are all the acronyms, ISNP, DSNP, that when you're working in the ACO space, these are the things that they'll talk about. How many of you have been in meetings and you hear acronym after acronym? I mean, we're really in the healthcare industry very guilty of doing that, but I would become very familiar with a lot of these acronyms if you're going to be working and trying to negotiate or becoming part of their networks. So, getting to know the terminology, first of all, hospices are aligned with the concept of where healthcare is going. So that is really important to know about ACOs. We already have been working around this. We've worked in somewhat of a per diem market that we have had to manage care with a fixed rate. And so we're accustomed to what our healthcare industry is now getting to, which is risk. and is managing our patients and putting patients in the appropriate place at the right time. So that is kind of our wheelhouse. So don't be afraid, be confident that we understand, what they're looking for and where we're trying to get to. So that's a really important thing, first of all. We also value-based or risk-based arrangements. If you're thinking that, oh, that's down the road, that's something that I don't have to worry about, it's here. I mean, I don't know how many of you in your markets that you are part of a VBID contract, but they're here. And they just announced, and I have a slide and an article later on that shares that CMS just decided, Centers for Medicare and Medicaid, just decided that they're going to extend the VBID till 2030. Everybody thought it was a demonstration project, it was a pilot, it's here. And now it's been extended to 2030 and probably most likely will be here to stay. So what does that mean? We're probably gonna get, if you are already part of a VBID contract, a haircut just for participating. And so you have to really get savvy about how are we going to work in these networks? What are we gonna do as hospice organizations to really make ourselves attractive and to be a part of this change and this growing area that's here. Go ahead.
So then the healthcare landscape, so we're going to cover really what do we need to know. This first part is going to be a broad brushstrokes of the entire kind of post-acute healthcare landscape, where we're at, where we're going, what's new, what are the things we need to be looking out for. So that way when we're talking about accountable care organizations and really value-based care designs, that you guys kind of have that backdrop and we make sure everybody's on the same page with where we're going. So we'll talk about hospice challenges and trends, home care trends, payer and provider spaces, value-based payment models that are here and are coming, and then hospice and end-of-life care options.
So let's talk about challenges. I think all of these are going to resonate with you. First of all, how many of you had staffing and recruitment challenges? If I don't see everybody raise their hand, I'll be shocked, or I want to find you. Competitive landscape. In my market, just in the Denver market, there's 58 hospices. I'm sure there's quite a few in your markets as well. So it's a competitive landscape, but also not only just hospices, you have other paths or organizations that are now entering, like PACE. You have different types of companies that are building networks. You have others that are offering more service lines. So not only do you just have hospice competitors, you have a number of other organizations that are also competing for the same type of clients. Then you add in all the benefit changes, right? The Medicare Advantage. You have what I just shared with ACOs and VBIDs and networks popping up. So you have that going on. We then, as we always have, regulatory environment that we have to deal with. We have reimbursement changes that happen every year. Is it going up? Is it going down? All of those things that you have to manage. HIS scores, CAPS, you have all of that we have to deal with. Public reporting, and then technology. So, gosh, who doesn't love technology? But if we're not investing in it, that's also the way of the future. I mean, how many of you implemented telehealth because of COVID? That got up so quick and running, but it's probably here to stay. They just announced that face-to-face encounters can now continue to be done by telehealth. And so there are things that you really do have to invest, and you're going to see when you start to work with the ACOs and VBIDs, they want reporting, they want outcomes, they want data. So technology does need to be one of our secret sauce that we add to our organizations so that we're in a position to kind of help present how good we are and why we need to be a part of their network. The other items that I see as trends, we get limited revenue. So growth opportunities in traditional hospice with increasing costs. So because of COVID, how many of you know your death service ratios in your state? There are a lot of people that died due to COVID that may have been hospice people down the road. So it decreased our population. I talked about competition. I talked about the other substitute competition. Jeremy is part of a PACE program. We're getting ready at Care Synergy. We were just approved by the state of Colorado to open up PACE. We also have palliative care. And then there's a lot of ISNP and DSNP plans that are starting to get into the network and open up their own ACOs. How many of you have heard of LHC? Do we have anybody here from LHC? You know, there's a lot that's happening in this area. Pricing pressures. If you are part of a Medicare Advantage value-based insurance design, MAV bid, you will automatically, depending on what you negotiated and how great you negotiated, will probably take a haircut. We're part of the Humana V bid, and they wouldn't do any better than 85%. And so traditional fee-for-service Medicare, when you're getting into this space, is no longer there. You're going to have some type of negotiated rate that's off of Medicare. The other trends that we see, the forward-thinking hospices, which I'm sure there's a lot of you in here, are starting to say, okay, what do I need to do? Do I expand my territory or my reach so I can get more people? Do we figure out how to become a network? Do you become like in my situation where a lot of hospices came together and we created a collaborative so that we share the back office, but they all still have their same name, their logo, their culture, but we have commonalities for volume purchasing. There's a lot of options that you can do that we'll share about, but those are some of the things that you need to walk away with today saying, okay, what are my options so that I can compete with other hospices in this space? So I just listed a few of the not-for-profits as well as some of the, I know Hospice of Michigan is here. Patrick was brilliant years ago and got a lot of different hospices coming together. So you're seeing some of that happen. Consolidation led by the large for-profits. How many of you have had a for-profit enter your market in the last 5 years? You know, they're buying up. I used to be with Hugh Henderson, part of Optum, which was United Healthcare's hospice division, and they would just buy. They bought all around the country. When I left, there were 22 offices. When I started, there were 2. So I mean, it just depends on, you know, who is doing what and where they want to be. And then the preferred provider networks. That is more of a local. That's where you have hospital systems who don't want to have to compete with dealing or interacting with 58 hospices. So what they're doing is they're creating PPNs, preferred provider networks, and they're picking 5 to 8 hospices that they're actually going to market and work with. And so that's who they'll refer to, but they're going to ask for data, they're going to ask for performance metrics, they want to keep their patients out of the hospitals, so it's not, for you to be a part of that network, you're going to have to be able to keep up with what do they want for their performance metrics and their KPIs. This is the debt service ratio. You can look at that later, but that's by state if you didn't know what it was for your market.
And I assume the slides will be available, right? So I see a lot of people writing furiously. Just know that all these slides with a lot of words on them, we want to make sure you have the information for later, because honestly, we start talking about this and it may pique some questions, but it may take some kind of ruminating on the information to come up with what you need. So all this information will be online. There's also at the end of our presentation, we also put some appendix slides in that go a little bit more in depth into ACO type things. So just know that all of these will be available, including these graphics and things. So don't feel like you have to try and look at the tiny print on the screen and see what your debt service ratio is. So home care and other agencies what are the trends that we're seeing with Medicare certified home health agencies? That's one of my backgrounds. I started out in the home health space. I have a doctorate in physical therapy, treated people in their homes, and then started running home health programs. So unit growth has been modulated by pricing pressures and staffing challenges. Does anybody here, in addition to their hospice, have a home health that's in as well? Does anybody here, before PDGM in 2020, thought home health was a great business unit, and after PDGM in 2020, go, holy crap, what are we going to do to make ends meet or to make things work or whatever? It was a big change. We have seen pricing pressures like we have never seen before through PDGM. We've also seen a lot of experimentation For those of you that are in the home health space, the value-based purchasing rules that are coming into play now that are trying to put a value add-on or a value takeaway from payments, you're going to see the word value through our presentation a lot. We are moving away from a fee-for-service model to everything having a value add to it in some respects. So there is a continued need for home care. There's a continued need for skilled home health. What that need takes is changing drastically. Like Tricia said, we're both involved in PACE programs that are becoming almost like competition to our home care programs. They almost become, and we'll talk about this a little bit later, some kind of type of internal competition to your hospice programs as well. So that's that piece of it. So then frail elder care, and again trends. So PACE. And then focusing on physician and practitioner practices for frail, elderly, homebound patients, facility-based patients. We'll talk more, again, sorry to keep teasing this, but we'll talk more again as we go through about our MSSP that we're a part of. Who here has heard of iSNP, DSNP? Okay, so iSNP, DSNP, if you guys, so think of an insurance company that's owned, managed by the facilities themselves. They take on the financial risk. Now, if you take that out into the community, you're talking PACE, you're talking some of these others. So it's all about taking on the financial risk. And I always use the analogy that Medicare would love in 2030 to go to Congress and say, I have X million people on Medicare, they are going to cost me X amount, and I have no risk going forward. That is what they would love. Because historically, Medicare takes on all the risk. Medicare says, hey, you worked for this, we pay for this, you have, it's a traditional insurance benefit. Whereas now when we're moving to the value-based benefit, they're pushing that risk downstream. They've pushed the risk downstream. You'll see in the ACO, it's pushed down onto the ACO and the providers to some extent. With PACE, it's pushed down onto the actual person taking on the PACE client. Same thing with iSNP and DSNP. So this market is really a land grab market. When you look at PACE, it has not been around for that long. There was one PACE program, Unlock, that has been around for a very long time. They were the originators of the PACE program, but it's only been really in the last 5 to 10 years that you've seen this land grab start to go on, where you are seeing both for-profit and not-for-profits look to diversify their business models by adding the PACE program to what they're already doing. I will tell you right now, we have a PACE program that since 2007, it went from being almost none of our revenue to today it's 80% of our revenue. So it drastically changes the way that hospices are able to function. So then the other piece, and Tricia kind of talked on this, not only in the home health space and the provider space, but you're seeing primary care practices. How many of you live in places that historically you had independent providers that then would refer to a couple of systems that now they are owned by the system? So we're seeing systems grab up primary care providers. You're seeing the number of independent practicing providers dwindle to almost not none, but is about as close to none as possible. And so we're seeing a real land grab in this frail elder care. I don't know how, there's not a real good way to encapsulate it because it goes across several business lines, but caring for frail elders, whether that's a SNFIS group, that's a PACE, that's an iSNP, that's a DSNP, that's any of these type of programs, that's where we're seeing the land grab start to happen right now. So then big picture in healthcare spending, you look trillions of dollars here. I wish it was only $4.12, but trillions of dollars. So $4.1 trillion spent on healthcare in 2020. You look back and you look at how that continues to increase. That's what's led us to where we are. So healthcare was 19.7% of the GNP in 2020, where it was only 7% of the GNP in 1970. So you're seeing a real change in the amount that as people begin to age, as we've been talking about the baby boomer generation for, I feel like, my entire career of preparing for that, and we're seeing it. You're starting to see, obviously we had an uptick with COVID. Everybody expects that to be a slight anomaly, but I don't think we're not gonna see that go back down. I mean, we're gonna continue to see that increase as a cost of our GNP. Hopefully it will level out a little bit as we start to get more of that data. But to this point, this is what we see as a steady uphill trend, which has led Medicare to say, hey, we can't keep doing this. We can't keep taking all the risk. We need to figure out how to do this differently. So then this is just a slide, and again, we'll cover this really quickly. You can see the United States at the top, per capita spend on healthcare compared to other places in the world. And then this is the big picture of where healthcare dollars are spent. Again, in trillions of dollars, so this is kind of breaking it down. And if you look clear at the bottom, that little tiny number is hospice. The big number up at the top, obviously hospitals, physicians, drugs, all of those sorts of things. And I don't know if any of you guys saw the report that came out that talked about how hospice saves the insurance company money. That was a recent report that came out. Sorry, I can't think of where it came out from on the top of my head. But did you?
Yeah.
So, and then this is this one yours or is this mine?
Or does it, this again in trillions, where's the money come from? So private health insurance, obviously at the top, Medicare next, and then on down the line. And then payers. Who are the largest payers? So obviously CVS and Aetna just merged. They're the largest. United Healthcare next, Cigna, all the way down the list. And then the senior living trends, the really big deal here is in the long-term care environment, they too are just like you're getting sicker people moving out of the hospitals into long-term care, but because they're joining and they're at risk, they want to manage their patients because they want to also, they may be part of an ACO that is at taking risk for their patients, so our length of stays might deteriorate a little bit. We had an organization in Florida that we're part of an ACO with that shared with Jeremy and I that they even had one of their partner ACOs that they have patients in this large long-term care facility and kind of a compound that said to them, look, we're going to really monitor when we can refer these patients because they were trying to manage them themselves and they were getting them in the last week, 2 weeks, whereas that really was hurting their relationship. So, I mean, it's happening.
Yeah, and kind of on that same pace, you may see, for some of you that see people in nursing homes that have I-SNP plans that use you as a provider, that hey, it's not 90-day lengths of stay, it's not 75, it's not 60, it's hey, after a 30-day length of stay, we want to have a meeting weekly on this patient of why were they on hospice and are we utilizing that benefit the best possible. In addition to that, if it's a VBID, which we're going to talk about in just a minute, they may say, hey, in addition to not keeping those patients on for 90 days, we also want you to take 9 to 17% less per day on your daily rate for treating that patient. And so, those are the pricing pressures that we've never seen in hospice before. Those are the pricing pieces that are going to start to make us really have to think. For those of you that do have a home health, you guys have experienced that. If you look back to 2000 when you first started, the PPS system, in the early 2000s, and you started to see that pricing pressure, that's what is kind of starting to happen to the hospice space as we allow MA plans to come in. The VBID design starts to take effect.
So this is the article that I was talking about, that they're saying that the shift to value-based care is here. It's inevitable. Jeremy kind of alluded to this, but also Medicare has come out and said that by 2030, they want all Medicare fee-for-service recipients, members, to be aligned with some type of managed organization. So will that happen? Will every fee-for-service Medicare member be aligned? Probably not, but that's the move. They want to get out of the risk. They want to shift it to somebody else.
And even those that aren't aligned and are in traditional Medicare, they want them in some sort of value-based plan where somebody else is taking on at least a portion of that risk or trying to drive down costs. So this is a table that is going to have a lot of stuff on it. It's meant to try and encapsulate the level of risk. Okay, so far left, CMS has all the risk. Far right, CMS has none of the risks. They pay a PMPM, a per member per month rate, a capitated rate for those patients. So if you look at your traditional fee for service, clear on the far left, we're going to spend a lot of time a little bit later talking about MSSP and REACH ACO, which kind of are in the middle. Okay, and then you look on the far right, and that's your Medicare Advantage plans, that's your special need plans, your ISNP, your PACE, some of your REACH ACO pieces, depending on what track that they take. But we thought this was important to put up here because as we go across this continuum, it's important to be able to place how much risk Medicare is shifting away from themselves and onto other people. So as we kind of go through this, think about your fee for service is the lowest risk to you, highest risk to Medicare. Your PACE, ISNP, Medicare Advantage plans, highest risk to you, lowest risk to Medicare, okay? So as we talk about that conversation, that will help fit that into that spectrum.
So Medicaid managed care, this just shows how many of those large players, where are they, and who's got the most. The MA trend, as I shared just a few minutes ago, it's going up. Look, in 2008, 19% of people were in an MA plan, and in 2022, 50% almost, 48% of people of Medicare age are aligned with a Medicare Advantage plan. Again, MA market, where do they fall? The largest, obviously, is, I think it's CVS. I don't see it up there. But United Healthcare, obviously very large. Humana is very large. This is another article that value-based insurance design model and the Medicare hospice benefit, they're actually seeing value. And so even though we're taking a haircut, there's value to it. So again, CMS will permit MAOs participating in the model to use more traditional MA approach. Now there are things, if you have an MA VBID plan in your market, learn what they offer. Some of them offer concurrent care, which means that they can have treatments while they get hospice. Some of them also offer that they get maybe 40 hours of a CNA, certified nurse's aide, while they get hospice. And so these are all things that you can also charge back to that VBID provider to get some additional revenue. So you need to learn what is your VBID program offering in your market, because it's not just the traditional hospice benefit. They might have add-ons to attract more MA members. And so those are things that you might be leaving revenue on the table if you don't know about that. So VBID extended to 2030. I already shared that. Humana, they were the largest player to jump in. They have been sending contracts to many of the hospices in their markets where they're doing it, and they pretty much are not negotiating. They're like, here's our contract, this is what we're going to pay, take it or leave it. And like I shared, we got one for 85%. So usually it's about 12% off of the Medicare rate. Aetna and United are very deliberately kind of starting to reach out, and especially knowing that CMS has extended it to 2030, I guarantee that they're going to probably jump in a little sooner than they had anticipated. Also, AvMed, for those of you, I don't know if anyone's in Florida, if you're familiar with them, they're seeing 20% discounts. Humana is still negotiating in CON states, so they don't care if it's a CON state or not. They're still going to negotiations. Concurrent care, I mentioned that's the treatments. Just make sure you define and understand, if you're in a VBID contract, what does concurrent care mean to that value-based insurance design provider. Let's see. I think that's really about it.
One of the things at the bottom I want to cover really quick, CareCentrix. Anybody here with a home health have to deal with CareCentrix for their small claims. So they're a third party that helps insurance companies give authorizations and make all of that. Anybody that's dealt with them, anyone in the room that I saw some shaking of heads, has never probably had a pleasant experience dealing with them. Whereas with a traditional, hospice patient, you sign them onto traditional Medicare benefit and you go. For a home health patient that has to go through CareCentrix, you're negotiating back and forth on rates, on number of visits, on all of those sorts of things. So when you even look at from a back office billing staff perspective as we go into VBID, what historically could have been a smaller billing staff per number of members on your hospice service compared to a home health company. If you look at a home health company billing staff, that's part of why you have the reduced overhead, because you're calling all these Medicare Advantage providers, you're begging for payment, those sorts of things, whereas in the hospice world, we haven't had to experience that quite as much. So those are some of the pricing pressures that as we talk through this and why we feel like it's important to bring this up now and what the current landscape is, those are the things we're starting to see when we work with our partners and what we're doing.
Yeah, and he's absolutely right. Your AR will increase. And so you'll have to put more, that's a margin compression. You now have to chase that money. And so that's something that you have to be prepared for. And I told Mark, I hope we don't sound like Debbie Downer, but this is here. This is what a lot of us are dealing with. And we will share in a few slides what we believe are ways for you to position yourself, to be not only prepared and learn their terminology and learn what you're dealing with, but how do you present it and how do you position yourself to really maybe even go after it and be ahead of the curve if you haven't already.
Well, and one other thing, and I don't know that we clearly put it on anything, but when you look at some of the VBID providers, and Tricia can tell you from their experience, they're going after people they don't want to write 55 contracts in a state. They want to have 2 contracts, 3 contracts in a state. And so their sell to you is, we'll increase your volume at a decrease. You'll get a decrease per daily rate, but we're going to increase your volume so much that it offsets it, which kind of is funny math when you think about it. But so that's the other piece, and we'll talk about this a little bit later on. But I think it's an important piece to keep in mind. There may only be 2 Aetna providers in an entire state. That you need to be able to cover that geography, or you need to be able to partner with people to cover that geography to make yourself how do you make yourself an attractive target for VBID?
So again, this is self-explanatory.
And this is the article I was talking about earlier, talking about how it actually saves money by proper use of hospice. So evaluating options. So now that we have, like Tricia said, efficiently been Debbie Downers. And to start, and that's what I said, you guys put us very first in the conference, and this is what we're going to say very first thing. But I promise we're going to talk about where we can go. And this is going to vary largely on your size, your scope, your geographic location. So we're going to try and cover a lot of different things that may be options, maybe things that you guys would be interested in talking about, and we're going to brush the surface of a lot of them. Tricia and I have either experienced or have contacts that have experienced any of these, that if there's a deeper conversation that you guys want to have with someone where, hey, this really seems like a path I want to run down, we're happy to be kind of that ongoing. But we want to try and brush as many of these topics as we can. And then again, through the forum, through talking through those things, hopefully answer as many questions as we can. But we're happy to have in-depth conversations on any of these going forward as well. So what's the path? I mean, you may come to the point in VBID where it's like, okay, what do we do? Do we increase our geography? Do we sell? Do we merge? Do we do all those things, which are not words anyone wants to say, but those are the realities of some of the conversations that hospices are going to start having over the next 5 years. So to evaluate your option, who's in your market, what business lines are needed or are being offered. If you're a hospice-only provider, what other business lines could you either spin up from scratch? Could you partner with somebody to joint venture on? Could you, I've learned more about joint ventures and, because we're both not-for-profits on member substitution models, all of those sorts of things that we can do to further expand and to insulate ourselves against all of these changes that we were just talking about. Do you have relationships with those partners? You may not be ready to jump in right now, but if you have stuck your head in the sand, you've ran your hospice operations, everybody is your competition, it's time to take your head out of the sand and start to evaluate who those partners could be down the road. This is not a crawl before we walk, before we run situation anymore. This is we're kind of jogging part way here. So, you've really got to make a concerted effort for those partnerships.
All right, so here's our checklist that we think if you can put these together, and like Jeremy said, this whole checklist might apply to all of you, or maybe there's one or two that you can focus on and it'll resonate. So relevance, to be viewed by stakeholders in your market, you need to be at the table. So first of all, do you know those partners? Do you know who's in your market? And do you want to be a partner with them? But you have to make yourself, your hospice, attractive. You want to be at the table and have those conversations. So if those preferred provider networks aren't happening now, maybe you want to go to a few of your hospital systems and talk to them about it and say, gosh, why are you dealing with 58 hospices? Just deal with 8, and this is why. And because we have X, Y, Z, and show them. And so be at the table. Make sure that you have the information that you can confidently be there and be one of those 8. Be innovative, so Jeremy said, are there other approaches, are there other things that we can do that you can be the leader in end-of-life care, or supportive care if you have palliative or other service lines. Vitality, to have economics that permit testing. Failure in a program, develop innovation, so you really need to have the reputation that they know that you are a player in your market. It's not always just size, it's quality of care, it's your HIS scores, it's your CAP scores. Some of the biggest in our market are not the best. They're not responsive, they cut costs on staffing, really promote what makes you innovative and the player that needs to be there. Indispensability, so the good that stakeholders must include in their network because we are a network, right? So in other words, who is in your market that is your best competition? Who would they be looking at? Sufficiently innovative program that some services might command premium pricing. Don't be afraid. So I'm going to share, Humana reached out to us. They were unhappy with their current palliative care provider because that palliative care provider wasn't moving their patients into hospice sooner. And so they reached out. We'd had a relationship because we were at the table with them on VBID. So now they're looking at palliative instead of just hospice. They got their hospice network in place. Now they're going to palliative. And they came to me and they said, we're going to pay you fee for service for your palliative visits. Well, how many of you know you go out, you do all that work around getting someone enrolled in palliative and then they choose not to enroll? Or they give you a list of 20 people and 2 of them really actually want palliative care because maybe their provider didn't have a conversation with them. Well, that's a lot of work to be paid fee for service that never happened. So we went back to them and said, wait a second, you're going to give us a whole roster. I've got to set up all this technology, bi-directional reporting. I want a per member per month. I want to be paid on this roster of people that may or may not come on board. And guess what? They said yes. So don't be afraid to go and have those kind of conversations, but you need to know what is it that you can do. Don't just, which traditionally hospices have done, we just take whatever we take. Let's be confident and let's be you have a great service to offer. And you see CMS is saying hospice is really saving money on our healthcare system. And have this kind of data to back you up to say, hey, I'm relevant. I belong at this table. There's a lot of people dying. This is the best care, the right place at the right time. We prevent readmissions. We prevent, invasive procedures. We educate around advanced care planning and end-of-life care. Be confident about your message.
So then to continue on kind of the checklist, and this is just as we're evaluating options, making sure that they fit what we felt when we were designing this presentation, we want it to be long-term. So, for those of you, like myself, we're in our 45th year of hospice business. I want to see another 45 years of hospice business. And this is the checklist we feel like we need to hit to be there. So to be competitive, so core hospice business is kind of a short to medium term economic engine, if you would say. Every business unit that you start has a maturity phase and you start to see it going to the decline phase, and are you going to reinvent yourself, or the most famous example that everybody uses, or are you going to become the Blockbuster of of what CMS is doing. So you got to start to reinvent yourself now and figure out what that next step is. Sales marketing expertise are as much cultural as functional. So that historically has not been a strength of community-based hospice providers. The marketing piece, what we always talked about, Tricia, you and I had the conversation last night. You don't sell hospice. Well, at this point, with the number of competitors you have in the market, with the number of different pricing pressures, all of those things, we're going to have to sell hospice to some extent. So be innovative. New programming is crucial. It's going to take money, people skills, and culture. And the reason that that's important is right now, if you are functioning at a and you have some margin, and you're able to have some margin, which is always great to talk about in healthcare. Some of that needs to be redeployed to being innovative, knowing that not every single one of those innovations is going to pan out 100% the way that you think, but you need to be setting aside some of that surplus to start to innovate and be available for partnerships, to be available to invest in technology and do those sorts of things. So it's a new way of kind of thinking through things, and includes relationship building to better understand the problems, working with payers, practices and hospitals, and then to be efficient. Being efficient won't drive the prosperity, but it will be crucial to have more efficiency than what we're used to. Having been in a legacy not-for-profit that has been profitable for a long time and early in the hospice game, the number of times that I talk to somebody and I'm like, why do we do it this way? Well, because that's the way we've always done it. That's the way that, why do we provide care in this way? Why have we never billed for our contract medical providers that are seeing people outside of that? Tricia and I had a conversation the other night about trying to, why have we never done this? Well, we just have never needed to, so we've never done it. Why do we spend on our advertising the way that we spend? Well, we've always had the money to do it, so we just do it. Those conversations need to start coming to light, and we need to start honing in on what are the essential things that move our business forward. So shared services always sound easier than it is. It sounds great to share services. It sounds great to partner with people, but I can tell you from experience in some of the stuff we're in the middle of, there are partnerships that I have been working on for 18 to 24 months that are still not close to done. And so it takes longer than what you think it is, which is why we feel like it's important that we have this information out here now, because this isn't something you can flip a switch on tomorrow. So joint purchasing in hospice is not substantial to drive savings. So GPOs are great. Integrated clinical networks are great. What we're finding is when you look at VBIG contracting, all of those sorts of things, they are not recognized by the payers as one network. So if you come together for purchasing, yes, you save money on the purchasing side, but you are not going to be able to give Humana, Aetna exactly what they want in signing that one contract, because you guys are just a loose affiliation. So those are things just to consider as we move forward.
So I think you got to look at what are your options. So are you going to continue to be a standalone independent? Are you going to add geographic expansion? Are you going to add service lines? Can you add palliative? Can you add capable, which is a program I'll share in a minute? Do you have home care? Another option is if you're a for-profit or not-for-profit, can you have an affiliation? The ACOs are at risk, and so they do need us. They need us to come in and really make sure that those patients are managed, and we can do it. We have the expertise of managing end-of-life care. If MA VBID is in your market, start looking to see who is and start to develop those relationships. If United Healthcare is a huge player in your market, start now trying to find out who are the people that you need to get to the table to, and talk with. And so those are things that we need to be doing today before they come into your environment if they're not there already. And then health systems, like I shared already, go to them and say, gosh, do you really want to deal with 58 hospices? Let's deal with 5, and I'd like to be one of them, and this is why. And so start those conversations. Contractual network, maybe there's an opportunity for you to share services like Jeremy was saying. This environment here is a great environment to get to know people. Is there a way that you can come together and use and leverage relationships that others have and kind of create an informal network so that you can get to meet others in larger organizations or be introduced to other ACOs that are out there. So this is a great environment that I'm happy to share the ACOs that I know of, because they do need hospices in their network.
And this is kind of a disclaimer before we jump into this. This is where, when we talked about how we're going to get in deep real fast, we've already kind of gotten deep into that stuff. We're going to start talking about ACOs. The disclaimer too is that if you spend much time with Tricia or I, you will understand that growth and opportunities kind of run through our blood. It's how we function. We're always looking for opportunities. We're always looking for what the next path is. And we have both been fortunate enough to work for leaders that also value that innovation. And so I think that's a piece of, for those of you that lead hospice and post-acute care companies, that's an important piece to start wrapping your mind around, is giving the people that work for you or the people that you put in positions to try and work on this the license to try and be innovative and think out of the box. I didn't know a darn thing about ACOs or MSSPs before 2 years ago when we started down this path. And so, in 2 years, I've gone from knowing nothing to feeling like I'm fairly proficient at it. I'm not going to say I'm an expert at all, but I'm fairly proficient at an ACO. So we're going to talk about the basic structure. We're going to relay through what we are doing right now. And then talk about also, like Mark talked about from the affiliation side, what ACOs are going to need on the back end. So MSSP, Medicare Shared Savings Plan, is the largest of the ACO products within CMS. It is a CMS, so I think we need to differentiate CMS, CMMI. So CMMI is innovation. Those are not permanent programs. That's where DCE was, for any of you that would know that then died out, was replaced with REACH, is now a CMMI program. MSSP is a CMS program, so it will take legislative changes for this program to disappear, which means it's more established than a program that's through CMMI. So CMMI is a great place to get involved in partnerships, but just know that those partnerships come and go on the whim of CMMI and the administration. We saw when we went from Trump to Biden administration that we were on a DCE track, which we'll talk about in a minute, and it completely died because of a change of an administration. Whereas this will be here regardless of administration. So formally authorized in 2012, prior to changes in 2023, there were changes in 2019. There were a lot of changes that came out in 2023. There are about 500 ACOs nationwide. Providers come together voluntarily to give highly coordinated, high-quality care to their fee-for-service Medicare patients. So the ACO then shares in the savings of the program. There's a minimum savings of between 3 and 3.9%, where you don't get anything in return. You get over that 3.9% and you will get savings. So then organizations starting with higher costs and are committed to cost containment can still succeed. So if you just read that entire slide and you knew nothing about ACOs, you still know nothing about ACOs. So I'm going to try and break down how I had to think about it just to finally wrap my mind around it. So the gatekeeper to the MSSP program is the primary care physician. So there has to be a primary care physician involved. The MSSP is a full 10 model, and if I cover some of the stuff in the other slides, I just think it's important to cover the big picture now. So 10, tax ID number. So the entire tax ID number from that physician is involved. You can't pick individual practitioners within a tax ID number to be involved. So it's entire practices that get involved. Okay? So then all their patients are fed into what's an attribution model. So attribution means that you got the more care than anybody else. So if you're the primary care provider, you saw that patient more than anybody else. There's some rules on it, which we have in our appendix slide, which I'm not going to cover right now, but then that patient becomes a part of your ACO. In the MSSP model, the physician still bills Medicare just like they did before. The difference is Medicare is now keeping score on the back end. Okay, so if they think that patient should have, I'm going to use easy numbers because not a math guy. I usually need my calculator with me. So if they think that that patient should have cost you $10,000 per year, and you come in at $6,000 per year, well, congratulations, you saved a significant amount of money. We're gonna split that money back with you. Okay? So that's the basics of how an ACO functions. You're given your list of patients that then you provide interventions for in some way, and then you hope at the back end that you reduce the total cost of care for those patients, and then that you get to share in some of those savings on the back end, okay? So that's kind of that's the basic functioning mechanism of it. There are lots of rules about how much and when and where and all of those things and how they can be split. So when you think about this, one of the things that I said and one of the opportunities from the hospice side is the intervention piece, okay? The physician practices are going to be looking for people to be providing interventions that keep their patients at home, out of the hospital, and doing the things that they need. It may be a palliative care intervention. It may be, so our ACO, to share a little bit of it, we're mostly facility-based, and so we do a lot of palliative care within our facilities to provide advanced care planning, to provide chronic disease management in the hopes that those patients do not go back to the hospital. Because the biggest thing that will make or break an ACO budget is a patient going back to the hospital. So if you guys have ACOs in your network that you're talking with, start to have the conversation with them of, hey, we feel like we could coordinate with you guys to start keeping that patient out of the hospital. It may be, for those of you that are general practice and have both a hospice and home health, there's a home health component to this too, that, hey, we'll provide home health services to these patients when they have skilled needs at home. And if you limit your network, again, working on a preferred provider network, we will take these patients, we will take them on, we will make sure that there's these coordinated cares, we'll do the reporting, and then in return, you gain savings on the back end. So that is kind of the basic structure. We're gonna jump off from here and kind of go through.
I just want to share that you need to educate your sales force that they need to start asking the question of physicians, is this physician practice part of an ACO? Because if they are, or a Medicare shared savings plan, that means they're at risk. And physicians historically haven't been great at managing their membership. And so, especially if they're focused on the frail and elderly, they may very well have a little bit more experience, but a lot of the primary care and internists and all that kind of stuff, they're not. And so if you know they're part of an ACO, they're at risk, and we can help them understand, and we're a solution for them. That we have expertise in managing this type of patient that costs them the most risk. Because what's the definition, or what's of a person who goes to the hospital? They're probably going to go to the hospital again. That's their MO. So I mean, it's going into a physician's practice and making sure that they understand, that you understand what they're up against. That's the first part, that we can help them with their frail and elderly patients.
Well, and on that same note, you're going to go to a lot of your physicians. You're going to say, "Are you in an ACO?" And they're going to go, "I don't know." Yeah. I'm going to move over here and see if that's any better. That stop it? Sorry, I was standing right underneath the speaker and was getting feedback. So, yeah.
I'm just curious, even talking about the rise of ACO, that it seems like it makes sense to bring on less medically frail patients onto your care, and you can better control costs of people that aren't cycling through the hospital system and whatnot. Does this pose like an access to care issue for people that are more medically delicate? Right, the way they're trying to go, because all these providers, talk about all these physician organizations and whatnot, seems like they make more money by bringing healthier people on service.
Right.
Well, there are ACOs that are just focused on frail and elderly, and so some of them don't want to get into that type of ACO or that Medicare shared savings program. There are some that they have a healthier population. And so they think, gosh, with my healthier population, I can manage that. But then it takes one patient who ends up getting diabetes or whatever the case may be that could throw them off. But it's an aggregate. It's not just, Each patient has an HCC code, which is hierarchical code. And so we all, if you're really healthy, are a 1. The sick are usually 3 or 4. So, I mean, they kind of know. Medicare gives you the claims data every year. So you know what patients in your population, in your practice, are what. So you can kind of target those sick people, and
think
that's
about
where
it
we
not
come
as
in.
not as a standard benchmark. There's not a benchmark for every patient that's the same. What they do is they go back 3 years and look at historical claims and say how much has that patient used in the last 3 months or in the last 3 years, and then they set the benchmark by that. Then so let's say that the patient is a 3.5 on an HCC score. That means they are 3.5 times more expensive than the normal patient. So then your budget gets increased by that much. So it's not that they won't be served, it's that you've got to have a specialized provider, because if they're the only 3.5 in the practice, that's totally different than if all your patients look exactly the same at a 2 to 3 and the way you provide interventions. Does that make sense? Yeah, go ahead.
You mentioned the difference earlier. You were talking about the big difference on Medicare related to physicians is that they're tracking it now.
Uh-huh.
Is that done through MIPS?
So that is done straight off of claims data.
Okay.
So that is straight right now what they're tracking as far as when you entered into the ACO, you sign on, you do all this stuff. We get a quarterly dump, or is it monthly? Quarterly dump.
We look at it quarterly.
We look at it quarterly of all of the claims data from the previous quarter. So we get the real-time claims data that wasn't available really on a fee-for-service basis, so you didn't need it. So that's what we look at, and that's what we, so then we feed that into a technology system that we have. So then I already covered this piece. So then this is, so to just give you a little background, the 1 minute, hopefully, version background of what we have done. So we are actually the owners of an ACO. So if you look at this map, here's the 10 organizations that own this ACO across the United States. We were fortunate enough to be a part of this. It's called Responsive Care Solutions. That's what RCS stands for. So right now, this is our first performance year in 2023. We have 32 different providers across the United States contributing about 6,400 patients. About 90% of them are nursing home based. Okay, so 90% of them are those frail, sick elders that we're looking at. The majority of the rest that aren't are more like ALF, IL type patients, so they're very facility based. So I'll just skip over this, but this just gives you an idea of who's in there, what the sizes of organizations, what services they offered going in to see kind of how you guys would, anybody would line up that was interested in something like that. So we're going to expand on the ACO model with ACO REACH model. Has anybody here heard of the ACO REACH model? Okay. So that's the new, that was the previous DCE, direct contracting entity, got revamped, changed the name, changed the rules to the ACO REACH model. So there's a low risk option, okay, where you're 50% at risk. So remember in the MSSP, and I guess I didn't really cover it, MSSP, the first 2 years you have no risk of downside. So if you don't meet the benchmark, you don't get any savings, but you don't have to pay a check back to Medicare. You get into the ACO REACH model, you have downside risk as well. So if you spend more than what the target is, the ACO is writing a check back to, and you can either have 50% or 100% risk depending on which track you take. And we'll skip the background slide here. You guys can read that. It just goes into kind of how this was formed. So I want to make sure we cover the capable piece, and then we have a little bit of a PACE piece at the end, because PACE is technically a Medicare Advantage plan, and then we'll hopefully give you guys a drink or a break to go to the bathroom, get a drink, and then you might need a drink this early in the morning. Sorry, and then come back and we can have a lot more discussion about what this would look like, because we have laid on a lot of information in the last however long we've been talking. So
yeah.
Go ahead and
So
capable.
CAPABLE stands for Community Aging in Place, Advancing Better Living for Elders. What a horrible acronym, right? It was created by Johns Hopkins University. It is one of the worst. It took me 2 years to remember that. It was created by Johns Hopkins University. It is a program that matches RNs with occupational therapists and a home modification company. The purpose of it, it's a 4 or 5 month program to keep people, aging people, in their home so they don't have to go into an assisted living or a nursing home. It's an incredible, brilliant model that is starting to get picked up by, right now we're working with 10 states that their Medicaid program is going to implement it. So this is going to be a big deal, I believe, in the future. Other countries, Nova Scotia just signed on, which is a province of Canada, but India has talked to us about it. Sydney, Australia has set it up because they want to keep people in their home. It's so expensive to go into assisted living, $8,000, $10,000 a month. So if you can come in and put some grab bars, move some rugs, help. It's a behavior modification program that teaches people how to face, as we age, future challenges that come their way. And so, again, if you're thinking of what are some easy setup service lines that you can provide in your market that might help you with some upstream, people, this is one of the ones that I think is starting to catch on. So just wanted to give a quick shout out to
this is when we talk about this. One, Trisha's too humble to say this, but Care Synergy is the national coordinator for the Capable program, so she is definitely an expert in this. We are becoming a site for this because we think it's important. But this is when I talked earlier about saving money for innovation and looking. This is an innovative piece. Trisha and I have been talking about this for 3 years, and they were early adopters in it, and I kind of pushed it to the side, and wish I would have jumped in a lot earlier than what I did. So these are some of the innovation pieces that it flips the script a little bit. Whether it's you are the partner in the ACO that now you're providing services straight to the practitioner that is sending you the referrals, or it's Capable where you come in and you say, I can solve this problem for this patient that doesn't want to go to the nursing home. I have funding available to go in and be able to modify their home. We're partnering with our local habitat to be able to do some of those modifications. You now become the person that bridges that gap. For anybody that has a home health company here or has worked in home health, especially in hospice, and gone in and been like, I know you need a grab bar, but there's no funding. I know you need a tub bench, but there's no funding. Here's the link on Amazon. We can order it through your DME provider, but here's how much it's going to cost. This is a way that we can start getting in front of that and start exploring options to be creative in that way. Yeah.
So right now, I'm seeing several of your accrediting bodies actually doing aging in place certifications. How does that impact with this, or does it?
So you don't have to have a certification. Capable will certify your RN, your OT, but there are certification companies out there. The piece we did reach out to Lowe's Livable Home because they had a similar type program. The big piece to this is the behavior modification. You can put a grab bar in, but if they don't know how to do it or they don't move the rug and they still slip and break their hip, then what have you taught them on how to use, how do they get up the stairs if they've been living downstairs the whole time because they can't go back upstairs to their bedroom because they're out of breath by the time they get there? How do you teach them to modify the home so that they can live there? And that's the piece that I don't know if all of the certification brings all the components together. If that does that answer your question?
So the last thing I want to cover really quickly is PACE. We've touched on it a few times. Like Tricia said, they were approved by the state of Colorado. We have had PACE since 2007. So Program for All-Inclusive Care of the Elderly is a value-based program where we take on 100% of the medical financial risk for patients 55 and older who have been deemed by the state in some way, it varies from state to state how that's done, to live in a nursing home. So we're taking care of nursing home eligible people in their homes. So we provide transportation for them. We have our own medical staff that sees them. We have day center services. We contract with hospitals, nursing homes, all of those sorts of places. But we take on 100% for the financial risk. If they come on service and the day after they have open heart surgery and $1 million worth of surgery, then that's our problem. And obviously there's insurances and reinsurances and all of that. But that is we are technically a Medicare Advantage plan for a very small, select population. I don't know how many of you subscribe to or read home care news online. They just did an article about expansion of rural PACE, the idea of expanding PACE into rural communities. There was a committee that came and talked to PACE organizations. They actually came to Midland, and we had that meeting at Midland with people from all over the country that then they wrote a report for Congress about expanding that out into rural communities because they're seeing a significant savings, especially most of the patients on this are dual eligible Medicare, Medicaid. And Medicaid is seeing a significant savings in the amount that they're spending per patient, giving us a PMPM, a per member per month, and not taking on any of the risk of those patients. And so we're starting to do that. So on this slide, there lists some of the largest. Innovage Denver in Colorado is the largest, which is actually right down the street from Tricia. And so, you can kind of go on down the list. If any of these are in your areas, they are going to be a large piece of the puzzle going forward. If you don't, and you can go onto the National PACE Association, NPA, and you can look and see all the PACEs that are in your area, but it would be good to know if anybody in your area has a PACE program or they're thinking of starting one. Because you come in and you say, hey, I know you're starting. Instead of hiring as many nurses to provide end-of-life care, what if you guys contracted with us? And PACE is another payer, so those patients actually get a PACE insurance card. They don't have the red, white, and blue Medicare card. They have a PACE insurance card. We'll accept a PACE payer at the contracted rate that you give us, and all of a sudden you're in a value-based system with them where you become the partner, and like Tricia said, you're at the table. So you're at the table for further conversations. So those are the types of things I would be looking at. We partner with home health and hospices outside of our core geographic region to hit some of our outliers. So especially some of you that may be on the fringes or in more of a rural space, it may be an option for you to look at as well. So that was the really quick down and dirty on PACE. If there's anything anybody wanted to discuss about PACE, we'd be happy to discuss further. But I want to make sure you guys get a break and everything as well. So,
Thank you very much.
Thank you.
Thank you.